This lecture is being brought to you in part by the generous gifts of these sponsors.
It is an absolute honor to be here today. I've actually sat in the seats that you guys are sitting in here a number of times, and it's an honor to be on the other side to share a story that's very personal to me. Two of my passions, which encompass both nutrition, but also a unique disease that I happen to have, which is called type 1 diabetes, and the combination of which has really guided my career. But the title of today's talk will be on which will be important, the specifics of that later on in the talk, low-carbohydrate diet for type 1 diabetes. Patient, myself, but also a research perspective on this. I am Andrew Koutnik with Institute of Human Machine Cognition, also USF Morsani College of Medicine. So I want to start with an outline of what the talk will actually be about today. First, I want to tell you, for those who aren't familiar, and I'm sure there are people in this audience who are very familiar with the disease that I currently live with, which is type 1 diabetes. But I want to describe the disease for those who aren't familiar, but also describe the most important outcome of this disease for managing it, which is glycemic control. I want to talk about that for its impact that it actually has on someone like myself, both acutely and also chronically. I also want to describe a very emergent topic, a very interesting topic, which is nutrition-based therapies for that, specifically a very low-carbohydrate diet, both my own personal perspective, but also a research perspective on this topic. I also want to discuss many of the common concerns and criticisms, as there are many that are talked about in the context of this diet, but also for this disease state, and also talk about what's the bigger picture of this nutritional strategy for this disease, and also moving forward as well. What's on the horizon in regards to type 1 diabetes? First, I want to talk about disclosures, as there might be some conflict of interest you guys should know about. I have provisional patents on the use of therapeutic ketones. More specific to something that may bias what I have to say here today is I have actually undertaken a number of nutritional interventions to attempt to manage this disease, type 1 diabetes, including high fat, low carb, high carb, low fat, flexible dieting, carb cycling, a whole host of different strategies. But very much biasing the way I think about this is that I currently do prescribe to a very low carbohydrate diet. And I'll describe here today why that actually is. And of course, I am not a physician, and this is not medical advice, but rather a discussion of the literature on this topic. So when we look at type 1 diabetes from an epidemiological perspective, if we were to take 300 people, okay, so let's say if there was 300 people in this room, out of those 300 people, there would be one type 1 diabetic. That means about a little over a million individuals in the United States right now with type 1 diabetes. And as you can see, that one person has their hands up like, well, why me? Why am I the person with type 1 diabetes? And unfortunately, we don't necessarily know that answer right now. But what we do know about type 1 diabetes is that it's an autoimmune disease. This is a disease where a very important organ in our body called the pancreas, which plays a really important role in metabolism, a part of that organ is attacked by our own immune system. So just like you get a bacterial infection or a virus infection, you can have an immune response that hopefully is appropriate and handles that adverse infection. Well, in the context of type 1 diabetes, you actually develop autoimmunity to portions of this pancreas called the beta cell, which actually produce insulin, this really important molecule of regulating blood sugar response, as is illustrated here. Now, what does it actually look like from a dietary metabolism perspective? Because I can show you this, but what's the meaning of that? What does that actually manifest as? And I'm going to give you a schematic, metabolically speaking, of the meal-by-meal implications of, let's say, if you were to eat a donut, right? So if you were to eat this food, or like say potatoes or rice or any of these foods in the form of carbohydrates, when you consume them, they're broken down in the gut, and then the breakdown of these foods can then elevate blood sugar levels. Now, if you have a normal, healthy response to this elevation in blood sugar, your pancreas, this really important organ, will now secrete an appropriate and well-timed match to the blood sugar to appropriately take the glucose from the food and actually shuttle it into various organs, such as the liver, muscle, and adipose tissue, amongst others. However, of course, then this brings down your blood sugar into the normal healthy range, which normal healthy blood sugars are about 80 to 120 based on the medical literature. But what happens if you're a type 1 diabetic and your immune system tells your your pancreas that portions of it shouldn't exist, and kills it off, specifically the beta cells. Well, that pancreas is no longer going to be fully functional, and you're going to have an attenuated or a complete absence insulin response to these elevation in blood sugar. Well, what happens when that's the case? Well, you're not going to shuttle the glucose into these tissues, leaving it in the blood, which we know can have consequences, which we'll talk about a little later. Of course, this keeps blood sugar elevated. This, of course, requires the exogenous administration or the administration of insulin outside the body. This actually led to a Nobel Prize back in the 1920s during its initial discovery, because before that, patients would only last months at best, sometimes days to weeks, whereas now someone like myself can last years and potentially a very full life. But very important to this disease state is the glycemic response to foods. This is one of the biggest modifiers to our blood glucose levels on a day in and day out basis. So when we look at various types of food, you can see carbohydrates there in the red, protein in the green, and fat in the blue. Carbohydrates have the most robust, in absolute relative terms, largest elevation in blood sugar. Protein can also elevate blood sugar levels, although this is not commonly discussed, it does. But usually it's a much more subtle elevation and much more prolonged. Fat has a very inconsequential effect on blood sugar levels. But when you look at this graph, a normal healthy individual typically wouldn't see much of a blood sugar elevation in general because they have a very appropriate and robust response to these blood sugar elevations. So this is actually more of an illustration of someone who might have type 2 diabetes where the response is a little delayed and resistant. So this is in the context of insulin. But what happens if you're a type 1 diabetic and you don't take insulin to one of these foods, either carbohydrates, protein, or fat? It looks much different. The blood sugar goes much higher and it stays elevated until you have something to bring it down. And in the context of a type 1 diabetic, that's the most prominent way of doing so is insulin. So what actually goes into the meal-by-meal decision-making of choosing which foods to eat every single day or choosing how to manage a meal? Well, this is an articulation or illustration of what goes into every single meal, every single day for a type 1 diabetic and the decisions they have to make and what they have to know, not only about their food, but also about their body. And to kind of go through this, the first thing that will happen as a type 1 diabetic, if you're going to go eat a meal, is you're going to find out what your blood sugar is first, okay? Is it 80 to 120, or is it lower than 80, or higher than 120? This will, of course, influence, do you need to take insulin just for your steady state blood sugar right here and right now? But you also need to know what's in your meal every single day. How many carbohydrates in the meal? What type of carbohydrates? The composition. Does it include protein? Does it include fat? All these things can influence not only the blood sugar elevation, but also the rate at which it assimilates into the blood. But what's often unappreciated, but very appreciated by anyone who has type 1 diabetes, is that there's a number of factors that can influence how the insulin will actually affect this blood sugar level. If you give 1 unit today or 1 unit tomorrow, it can have a completely different response. And the reason for that is because things like exercise, sleep, medication, illness, caffeine, hormonal fluctuations, the time of day, every single day, can influence the insulin response on blood sugar. But this is just a small list. There's actually a whole host of things that influence the dynamics of our metabolism, which you get a front row seat if you're a type 1 diabetic. Ultimately, after you make a decision with what your blood sugar is, or find out what your blood sugar is, and then you find out or understand what's in your food, which you truly have to be an expert of lifestyle and nutrition to manage this disease, is then to determine, do you want to use short-acting, medium-acting, long-acting insulin, and then how much do you want to give? Of course, I would argue this is not an easy decision and of course can be quite daunting a lot of times. But what is the actual glycemic outcome that is typically achieved by someone in my position who's making these decisions every single day with all these variables? I'm going to show you an illustration of a typical day in type 1 diabetes for blood sugar. And it looks like this. This is actually not uncommon of a diagram of a type 1 diabetic. In fact, I would argue this might be better than the average, where you see fluctuations up and down often at every single meal. And it's important to appreciate that this is normal. Normal is somewhere between 80 and 120, and oftentimes in the literature for type 1 diabetes, they describe it as 70 to 120. Give it a little more wiggle room. But most of this graph is not in that range. In fact, it's either below or above that range. So what happens if you go above? Well, this is termed hyperglycemia, or the elevation of blood sugar above normal range. And these have consequences. These cause symptoms anytime it happens, and these include blurred vision, disrupted concentration. Fatigue is very common. But if severe enough, it can actually cause the most common reason for someone being diagnosed with type 1 diabetes, which is diabetic ketoacidosis. And if left unmanaged, that can actually be fatal. But the more acute concern for most people with type 1 diabetes is this, which is hypoglycemia, which is a relative reduction in the amount of glucose in the blood. This can cause shaking and sweating, irritability for sure, but it's much more severe because it can actually lead to someone losing consciousness, going into a coma, having a seizure, but if severe enough, it can actually cause death acutely. So if I were to go take too much insulin right now, with my insulin over there, this can happen to me. And this does happen a lot of times, often at night for type 1 diabetics who mismanage their insulin right before bed. So oftentimes type 1 diabetics are accumulating symptoms of both hyper and hypoglycemia, often meal by meal. But what does a typical week look like? A typical week was actually given as an example in a recent publication, Endotest in 2016, but this is what the blood sugar tracings of a type 1 diabetic looks like on average. Again, showing you normal in green, but for this patient, the example patient here, is the average blood sugar is in red. And as you can see, the average is not really just a steady blood sugar number. It's variable above and below that, often chronically. But you can look at a typical day, you can look at a typical week, but what we really want to know is what is the blood sugar over a chronic period of time. And one of the best metrics to do that is this thing called hemoglobin A1C. Now, I'm sure almost everyone in this room has actually had a test for hemoglobin A1C before because it's a diagnostic criteria for actually being diagnosed with diabetes. And how it works is, let's take that example graph shown over there on the left. That actually is about an average of a blood sugar about 151 with a standard deviation of 58 milligrams per deciliter above and below, which means that this patient's average blood sugar is 30 milligrams per deciliter higher than the high end of normal, and is fluctuating over 100 points up and down daily. Over a 2 to 3 month period of time, that leads to elevations in the average blood sugar circulating in your blood. And we now appreciate, and have for some time now, that glucose can spontaneously or enzymatically bind to various tissues or components in our body. And one of those is actually red blood cells, a portion of the red blood cell called hemoglobin. Now, of course, the more circulating glucose you have, the more chance it has to bind to hemoglobin, and this can elevate something called glycosylated red blood cell, or termed clinically is HbA1c. So, as I had mentioned, this is used as a diagnostic criteria, and this is an outlay of what would be normal, pre-diabetic, and diabetic based on what the unit, which is a percentage for HbA1c, which is 4.4 to 5.6 is termed normal. The correlated or associated blood sugar are below that, which is 80 to 114. 5.7 to 6.4 is termed pre-diabetic, but anything over 6.5 is clinically determined to be diabetic. But the question has arisen, where does type 1 diabetes actually fall into the spectrum? Because typically that diabetic range is for a type 2 diabetes scenario. There's been a number of numbers ascribed to what is actually a type 1 diabetic's HbA1c, or their chronic metric of blood sugar. So I actually went and looked myself to find out what was in the literature. And I found a number of studies looking at some of the largest epidemiological studies, or RCTs, which are called clinical trials, looking at the largest population sets I could find and their HbA1cs that they reported. And what you can see is that the average HbA1c ranges somewhere between 7 and 9, putting the average for a type 1 diabetic in all these studies combined here, and there are more that show the same findings, and this here is just about over 400,000 patients shown here, of about 8%. So back on this graph, the average type 1 diabetic sits between 154 milligrams per deciliter and 212 milligrams per deciliter, between 7 and 9% HbA1c. But it's not just about the average blood sugar level. It's also about the stability or variability in blood sugar that we see meal by meal. And there was a study, one, and it might be kind of hard to see this graph, so I'll read some of the numbers to you, that actually looked at the glycemic stability of type 1 and type 2 diabetics. But I'm going to harp on the type 1 diabetes component here. This was in 268 type 1 diabetic patients. These patients actually had a HbA1c of what would be termed the recommended HbA1c, which is less than 7.5. I put quotes around that because that's what is typically recommended based on lower complications, but it's not normal by any means. These patients actually had a 7.3. They fall into this recommended range, quotes around that. But their average blood sugar was 162 on average, but their standard deviation was 64.8. Again, this is not uncommon in type 1 diabetes to have dramatic fluctuations up and down around the mean in blood sugar. And at the bottom here, you won't be able to see this probably down there, but 96% of patients actually had outside of the normal blood sugar variability. And as I mentioned before, that glycemic variability can affect the way you feel every single day if it's outside that normal range. And as you can see, the variability is quite robust in these patients. And what this study showed was that less than 4% of type 1 diabetics, even though they had the recommended HbA1c, illustrating they were more controlled type 1 diabetics, actually had normal glycemic stability. Less than 4% did. And again, this is back to this graph showing that it's variable. This is the cause of that. Now, there have been emergent technologies over the years. There's new technologies. There's continuous blood glucose monitors. I actually have one on me right now. There's infusion pumps. There's actually automated system now that automatically will give you insulin based on your blood sugar. There's newer drugs. There's all sorts of newer technologies that have emerged to help patients in my situation. But is that making things better? Unfortunately, there was an analysis showing that in 2010 to 2012, actually to now, the average blood sugar level has gone up, not down, illustrating that things aren't getting better. In fact, there's been some literature illustrating that it hasn't improved in 30 years with what's currently available. And that has impact on a regular basis. So let's say you had the normal blood sugar of 80 to 120, and you're a type 1 diabetic and you have the typical blood sugar, it's elevated. This has consequences to the biochemistry of our body. It can induce things like inflammation, advanced glycosylating enzymes, or AGEs, reactive oxygen species, epigenetic modifications. There's a whole host of ways in which this can actually induce the damage that we see in outcomes. Well, what are those outcomes? I think this is important to mention because actually when I was diagnosed, I was never told this. And I think it's important to appreciate because it is a motivating factor to do better with your glycemic control. This publication looked at a very large cohort of patients trying to determine what were the chronic outcomes in patients with type 1 diabetes. It actually was in JAMA, which is one of the most prestigious journals in medicine currently. And what they did is they did an evaluation of some of the top 10 leading causes of death to find out where type 1 diabetics were at increased risk between males and females or across the age group. And I'm going to highlight in here anywhere where a type 1 diabetic was at increased risk. Here. It's pretty overwhelming, right? So type 1 diabetics currently right now are at increased risk for all 10 of the leading causes of death, in some cases quite robustly. But this actually doesn't illustrate the most consequential facet of this disease or their outcomes. This same study also looked at survival in these patients. And this is the average anticipated survival curve of someone without type 1 diabetes. But males on the left and females on the right, those with type 1 diabetes are actually expected to live a decade shorter than their non-type 1 diabetic counterparts. And this is not the only study to show this. There's actually been 3 analyses so far, one which was in Lancet showing that the earlier you're diagnosed, the more accumulation of glycemic mismanagement you have, the higher your risk for early death is. And actually they estimated if you were a female diagnosed at the earliest stage, your anticipated survival is 2 decades shorter. So there's pretty robust impacts here. So if you're someone like myself and you have type 1 diabetes and you know about this and you know that glycemic mismanagement is causing these outcomes, because that's what's shown in the literature, it might bring up a question, well, if glucose has the impact, or these carbohydrate-based foods have the impact they do on glycemic control every single meal, well, is it logical to potentially just do a diet that lowers the carbohydrates, a very low carbohydrate diet? Well, that kind of gets to my personal story. This is where I'm a little biased in this because I've had type 1 diabetes for 13 years, going on over 13 years. And 12 years into that, I actually switched to a very low carbohydrate diet and adjusted my insulin regimen. I've tried other approaches along the way as well. And what does this actually look like in a meal? Now this is I would say it's a standard diet meal, but that's a lie. This is actually a healthier version of a standard diet with chicken, potatoes, spinach, and kiwi fruit. But what this really looks like is you're replacing the starchy, sugary carbohydrates for things like healthy fats, like almonds. But along the way, I also switched my insulin when I switched my diet, going from approximately between 90 to 100 IUs per day to actually reducing my insulin requirements to about 20 to 25 IUs per day when I switched onto this diet. This was about a 70% reduction in the primary medication used to treat this disease. Financially, this also has consequences. I did an estimation recently of the cost before of insulin per month. This is absent insulin, so of course that would change things, but this was the cost after. This is a dramatic reduction in the cost of actually managing this disease every single day by reducing the amount of insulin given. And I'm not unique either, and I'll describe that later. But what is the real change here? Because of course, when you see these blood sugar responses and you see the symptoms, this is affecting how someone like myself will feel every single day. Well, afterwards, this is what my blood sugar looked like by using this approach. It's a much more stabilized, controlled lifestyle that completely revolutionized my own quality of life. Now, I could show you a blip it and say, okay, this is 1 week versus 1 week pre, 1 week post, this is all the time. But that might not be the case. So this is an average over a 60-day period of time, showing that my average blood sugar is that black line in the center there, and the red line is 70, and the top line is 120, the yellow line, showing that my blood sugar on average was sitting in the normal range, and the standard deviation was allowing me to stay almost all the time in normal range. But again, I could show you these graphs and say, well, look at what that achieved, but again, this metric that's associated with risk and almost chronic marker of blood sugar control over time is HbA1c. So where did I fit in this realm? A 4.9 HbA1c when I switched. So this placed me into the normal non-diabetic range. Now, I could tell you, and I am proud of this. I won't sit back here and say like, no big deal. I'm super proud of this because this revolutionized my life. But if I'm telling you I did it, that doesn't mean that everyone else is going to have success with this. That would be false hope. You can always see stories of someone who was able to do something, but it might not work for everyone. So what does the actual research say on low carbohydrate diets and type 1 diabetes? Is this first a new idea? It's absolutely not a new idea. In fact, this was the standard of care for patients when they were first diagnosed to extend their life, because if you did a high carbohydrate approach, it often led to them getting ketoacidosis and they would die almost immediately in the absence of insulin. So they did this approach initially. But back in the 1950s, it fell out of favor because it was deemed to be too restrictive to reduce carbohydrates in the diet, especially when insulin became available shortly after the 1920s. But what does the current data say? Unfortunately, very limited. This was a meta-analysis that I'm going to describe by Turton et al. In +1. And a meta-analysis is a cluster of studies looking at a category. And in this case, he looked at type 1 diabetes and low carbohydrate diets. And this is a schematic looking at all those diets for various metrics, both in the type of low carb, because there's really not a unifying definition currently for what low carbohydrate means. The average population eats over 45% by kcal carbohydrates. So a lot of people term low carbohydrate as less than 45% by kcal. However, a lot of people in the research world that I work in, less than 50 grams per day is what's considered low carb. So there's different definitions. So these authors also looked at different definitions and how they fared, different types of diets based on different definitions, but all low carb in different categories. They also looked at different metrics of glycemic control for type 1 diabetes, like the HbA1c I told you, but also things like hypoglycemic risk, that acute risk of going too low, amongst other metrics. And to kind of summarize for you, I'm going to read this verbatim. It says, due to the significant heterogeneity of the inclusion studies, an overall effect could not be determined for low carbohydrate diets and type 1 diabetes. So this study published last year, illustrated there wasn't enough data to really give informed decisions based on the research of whether this will work or not for patients like myself. However, with my own personal experience with type 1 diabetes and knowing a lot of people who've done this approach and had success in type 1 diabetes, the number of carbohydrates seems to really matter. And once you go above a certain level, you're chasing numbers. But once you have it below a certain number, there seems to be a good amount of success found below 50 grams per day. A lot of people like to do much lower than that. So when you actually look at these studies, the false low carb, which was around 45 to 26% by kcal carbs, to less than 26% by kcal carbs, or again, this true low carb, which would be deemed less than 50, or not true, but very low carbohydrate, which we're talking about here today, less than 50 grams per day. But what you find is when you subset out those studies that were actually found that, those were the only studies where consistent improvements were actually found in glycemic management. And these are the two studies here. And as you can see, there's a very limited population, just 2 studies that were included in that previous meta-analysis, only include 11 patients. And if you include me, that's 12, right? That's not a whole lot. But they did find something really remarkable, that these patients did decrease their insulin requirements, and they also had normal, healthy, non-diabetic HbA1c levels. There are very few studies in type 1 diabetes where any therapy was actually able to achieve those numbers. That's a very big deal. But again, it's very limited. It's hard to inform decisions off that. But there was this really big study out of Harvard and Duke last year. They came out after this meta-analysis. What did this study actually find? Well, first, it was the largest analysis ever of patients using with type 1 diabetes actually using a low carbohydrate diet. 42% of these patients were actually children. And they were using less than 50 grams per day. Around the 30 to 40 grams per day was the average. And it was actually looking at a unique group that I'm actually a part of called Type 1 Grit. That is a very motivated group of type 1 diabetics with their mantra is to use low carb to manage their disease. They actually found in this study that in 300 participants that the average HbA1c was less than 5.7. 5.7 is the cutoff to start prediabetes. 300 participants were able to achieve non-diabetic chronic metrics of glycemic control. Less than 2% of type 1 diabetics achieve this right now. But it goes beyond that. They were actually able to normalize their blood sugar variability into the range of a normal non-diabetic range as well, and that's less than 4% of type 1 diabetics based on the literature, but it is limited literature to go off to indicate that. They also reduced the second risk factor for cardiovascular disease in type 1 diabetes, elevations in HDL. There was less than 2% of the patients actually had any adverse events like hospitalization, and 87%, although this is biased because they choose to do this, 87% of these patients found this dietary approach satisfactory. And it's important to mention that no children on this approach saw any growth impairment. This is a concern that some clinicians have about this diet. In summary, the glycemic outcomes achieved by these patients are unmatched by any other therapy available to someone like myself with type 1 diabetes. There is no therapy that does this right now that a patient can go implement right now. But are these consistent findings? These are the 2 studies I showed you before, but since that meta-analysis, which actually analyzed data from 2017 back, and they got it published in 2018, there have been 4 more studies looking at very low carbohydrate diets. And you can actually see that in all these studies, with less than 50 grams per day, that every single one of them decreased the insulin requirements utilized to manage this disease, or had insulin levels that were lower than historical averages. And when you look at HbA1c, every single study that was as long as 3 months or longer, which it takes about 2 to 3 months to change HbA1c, every single study that was at least 3 months or longer had normal, non-diabetic glycemic control metrics. They also saw impeccable, where it was analyzed, impeccably low variability in their blood sugar. This is showing that these patients were basically representing non-diabetic numbers utilizing this approach. In summary, this is really showing that the available evidence right now indicates that a very low carbohydrate diet of less than or equal to 50 grams per day improves glycemic control better than any other currently available therapy right now. And that's based on the evidence we know. But there are big howevers mentioned. As I've spoke at some clinics before and some endocrinologists and have heard many concerns or criticisms, and I hope to be able to address the most prominently articulated criticisms that are brought up to me about this approach. because I think that's important. You can't ignore those, because some of these are very valid. So what are the concerns about low-carbohydrate diet, specifically in this population? First, ketoacidosis. So when you're diagnosed with type 1 diabetes, you're actually typically diagnosed because you actually have ketoacidosis. It's well known that a low-carbohydrate diet could elevate ketone bodies. So couldn't a low-carbohydrate diet increase the risk for ketoacidosis? That's one concern. A second concern is hypoglycemic risk. If you're having less carbs in your diet, aren't you going to run the risk of having more hypoglycemic events? Pediatric growth. There's been some publications in seizure patients using a more restrictive form of the ketogenic diet, which is a 90% by kcal fat, where a small percentage of the patients had growth impairment. So won't kids with type 1 on a very low carbohydrate diet may experience that too? Cholesterol and long-term health. If a diet that is very high in fat, won't that alter my lipids and then have adverse effects on my chronic health? Protein and kidney function. It's been harped on that high protein levels may damage kidneys. And compliance and quality of life. Will patients even do this? And won't it affect their quality of life, their social habits? So here's an illustration to describe what the common concerns are that have been mentioned to me from the medical community, but what are the hopes that a very low carbohydrate can give based on the evidence we know? First, ketoacidosis. We know that ketoacidosis is actually associated with elevated HbA1c because it's associated with glycemic mismanagement. And the current evidence illustrates that a very low carbohydrate in type 1 diabetes is actually able to dramatically improve glycemic control in this population, reducing the most chronic metric of that is HbA1c. So it's reducing the two biggest risk factors for ketoacidosis. What about hypoglycemia, the risk of going too low? Well, hypoglycemia is actually associated with high variability within blood sugar numbers and actually is also associated with elevated HbA1c. It might seem illogical to think, well, my blood sugar is higher, how am I going lower? Because the fluctuations are often much more dramatic when your HbA1c is higher. The fluctuations are typically greater. And again, the diet reduces both of these. What about pediatric growth? The diet that was used in the papers that actually showed growth impairment was very different from the diet shown in these patients, where these participants just lowered carbohydrates, weren't necessarily trying to get quote unquote ketogenic. They had sufficient protein in this diet, more so than this 4-to-1, 90% by kcal diet, where growth impairment was shown in a small cohort of seizure patients. And we actually know that glycemic mismanagement actually increases the risk of growth impairment in children. So that actually can lead to growth impairment, and this diet can actually mitigate that risk factor because it does reduce glycemic mismanagement. Cholesterol and long-term health. The number 1 and number 2 risk factor for cardiovascular disease right now for type 1 diabetics, most recently published, is HbA1c is number 1, and number 2 is triglycerides. These are the hallmark changes of someone who does this with a low carbohydrate diet and type 1 diabetes well. So it's reducing the number 1 and number 2 risk factor. It also elevates HDL, reduces the insulin load, and it's been commonly associated with elevations of LDL, but there's been an emergence of evidence illustrating that there might be unique changes in LDL particle and also size, so particle size and number, that may have a more nuanced conversation that we have to soon learn about. So there's more to learn about HDL in this population using this diet. The last 2, protein and kidney dysfunction. There was a hypothesis paper published some time ago illustrating that high protein diets might harm kidneys. But there's a recent meta-analysis published by Stu Phillips illustrating that if you actually look at the change of the metric of kidney dysfunction, which is glomerular filtration rate, almost said that right, GFR, that actually doesn't change over time. A lot of the analysis on glomerular filtration rate, GFR, only look at absolute endpoints. They haven't looked at changes. And if you actually look at changes, you don't see these adverse events with high protein diets. And we know that elevated protein can actually contribute to important hormones like IGF-1, which can help support growth in children. And the last one, so compliance and quality of life. This is constantly brought up about will patients even follow this, and won't it affect their social life, their ability to eat normal foods at a birthday party? This is not a problem that is unique to low carbohydrate diets. In fact, if you compare low carbohydrate diets to all other diets currently, they all have compliance issues. It's hard to change your lifestyle, but this is not unique to low carb. This is to any diet currently. Also, because of the interest in low-carbohydrate diets, many of you who've probably been to other lectures describing low-carbohydrate diets for another utility, maybe performance, maybe cancer, maybe one of these. And because of that interest, there's been expanding food options. So you're not just eating, let's say, that steak with nuts and salad. I love that, but maybe you don't. So there's expanding options to be able to expand what you eat on a regular basis to give you more variety. And this last one is more so my personal opinion. I've seen a number of patients with type 1 diabetes, there has been evidence that this diet can improve quality of life, but the evidence is biased. But when you control your glycemia as a type 1 diabetic, it can revolutionize your life. It did for me. And I speculate that this would likely lead to improved compliance if it's actually mitigating the symptoms of your disease on a chronic basis. But again, this is just my personal opinion, so I put a question mark there. So when we look at this as a whole, though, because I went through some of the details there, but when we look at this big picture as a whole, often when the low-carbohydrate diet is brought up in discussion with type 1 diabetes, what you see is right here, above the surface, the concerns. Things like want to increase hyperglycemia, impair pediatric growth, increase LDL, induce ketoacidosis, low adherence and quality of life. Well, currently, there's only evidence for 2 of those right now, and not quality of life. Quality of life has actually been shown to improve, but in a biased analysis. But what's often missed, and actually under the surface, but often not talked about, is what's the benefits that a patient may derive from this diet. And they're quite robust. Things like dramatic reductions in the second leading risk factor for cardiovascular disease, reducing the number 1 risk factor for cardiovascular disease in type 1 diabetes, reducing the primary medical drug used for this disease, a whole host of other factors that are often missed. And it's really important, I believe, to look at both the benefits to risk and ratio and not just look at what you think concerns or prescribed potential concerns might be. And I want to leave on one last note here, which is, I didn't go into this. I have a whole website basically with all free information for people to go back and look at what I have to say here today, because I don't expect you to just say, oh, Andrew said that, that's truth. I hope you go back and double check everything I have to say. And so I made a website just for people to do that. But on that website, there's a list of all the commonly used therapeutic tools for type 1 diabetes. And without going into detail, these don't correct glycemia for patients. They can help, especially for motivated patients, but they don't correct it. But I don't really want to talk about that. What I want to talk about was a revolutionary study that came out in 2000. It literally revolutionized the field of type 1 diabetes. What they showed is, it's one of the most cited papers as well. What they showed is that patients were able to get islet cell transplants. They underwent surgery, took donor transplants from pancreases of cadavers, and implanted them in the patients. And what they found was that this study was able to normalize glycemia in these patients. I think it was in 7 patients, 7 patients. This revolutionized the field and funding and the belief that a cure was on the table for someone like myself. And one of the most cited papers of its time. But I want to do a comparison between that study and what a very low carbohydrate study has illustrated, because it's not all perfect. And in fact, in this publication, the clear benefit was that it dramatically improved glycemic control. But the cons to this are that it required a major surgical procedure. It also required chronic immunosuppressants. There's also a very limited donor supply to be able to give all type 1 diabetics pancreases. And actually, the pancreatic transplant only lasted for about a year before it started deteriorating. So it was actually not permanent. Now, they're improving this. The ability for these transplants to last longer is real, it's happening, but this is not a long-term solution. You're not going to get a transplant and it lasts forever, at least not right now. And actually, most patients are back on insulin. In fact, every single study I've seen, they're back on insulin. But when you compare this to, and I must also mention that if you talk to people who actually study curable options for type 1 diabetes, the reality that I have been informed of, and I'm not someone who's studying cures for type 1 diabetes, so I'm not that expert, but the people I've spoken to who are have told me that a cure is decades away. This is all the way to previous ADA presidents to people who study beta cell transplants. So I argue for someone like myself and patients who suffer from this disease, an option needs to be available now, or if there is one, they should know about it. And that brings up this comparison to the study like this, where they look at very low carbohydrate diets, where if you have a very low carbohydrate with a matched insulin regimen, it also does the same thing, dramatically improves glycemic control. And we're talking about less than 50 grams of low carbohydrate. But there are cons. You have to change your life. And it's a biggie for some people. And there's some concern about LDL cholesterol, but we have to learn more about that in this population. But when you compare these two, one study which revolutionized the field and was a temporary fix is something that every type 1 diabetic has available to them right now. I believe this is something that more type 1 diabetics should know about. So in summary, 80% of type 1 diabetics are actually not achieving the recommended glycemic targets, and actually less than 2% are achieving normal blood sugars, healthy normal blood sugar responses. And this hasn't improved in over 30 years. But, and on top of that, type 1 diabetics are actually at increased risk for all 10 of the leading causes of death, and actually are predicted to live at least a decade shorter than their peers. And again, this is all associated with glycemic mismanagement. But according to the available evidence we have right now, a very low carbohydrate diet can help patients achieve normal blood sugars, even into the non-diabetic range. And this has been a consistent finding in studies less than 50 grams per day. And this is unmatched by any therapy currently available. A true cure is unlikely at this point, and I articulate and believe that the benefits do outweigh the perceived risks that are on the table. But what's on the horizon for type 1 diabetes? Success of a very low carbohydrate diet is not an easy thing to do. It does require education not only from the patient, but also the physician as well. I don't know of many physicians who are taught how to implement this approach, but also match it with the appropriate insulin, and that's important. It's important to realize that this is an individualized choice. It's not a bad thing if you choose not to do this. It's not a bad or good thing if you do or don't. It's always an individualized choice. You need to find whether this works for you. But I argue that the available evidence indicates it should be on the table for patients with a disease of type 1 diabetes. What about future studies? There is actually 13 clinical trials now. When I took this photo, there was 12, but there's actually 13 now from groups all over, including places like Harvard, trying to really study what's going on with type 1 diabetes and ways to help type 1 diabetic patients using these approaches. But there are pitfalls of these studies that will hopefully be avoided, things like not bolusing for protein, which is important, poor diet formulation, caloric restriction, amongst others. These are things that, of course, will make it difficult to actually manage the disease well. And awareness. This is what I'm actually doing here today. I want to get out the message out there for someone like myself with my disease that there are options on the table, at least viewed as a tool in the toolbox for someone if they want the option. And I want to end here with just some resources for individuals. Throughout this entire talk, I mentioned a number of things, but may not have shown studies for them. On my website, I have 80 pages worth of material and over 200 references where I hope, if you're skeptical, I encourage that. Go back and double check everything I have to say and look to see what the evidence says for yourself and make your own informed decision. Let Me Be 83 is a non-for-profit that is specifically trying to help individuals who do this low carbohydrate approach to help them achieve glycemia or normal glycemia. And there's also recipes. Oftentimes it's believed, when I talk about these growing food options, I've made pizzas, donuts, cookies. I don't do that all the time, but you can actually make these foods, I argue, taste pretty freaking good on this diet. So you don't have to feel like you can never have pizza again. You're never gonna have a cookie. You're never gonna have a donut. You can make these options. You might have to put the effort in, but it's available, right? So Caroline's Keto Kitchen is a type 1 diabetic who also follows low carb and makes recipes for people to follow. And they're great. I've done them, and they do a great job of managing glucose control. So with that said, I will take your questions.
Okay, I see several right here. I'm going to toss you this, okay?
Okay, I guess the obvious question, if you look at this audience, is how does your philosophy translate to those of us who are more likely to be type 2 diabetics?
Right. There's a host of evidence on that. In fact, there's a huge company right now called Virta Health that's actually attempting to do telemedicine for patients because of the success they've been able to find in helping manage type 2 diabetics with this approach. So this is actually brought up as an approach for type 2 diabetes before type 1 and has a lot more literature supporting its utility compared to the limited literature I showed here today for type 1. So to answer your question, there's a ton of literature on that. I didn't discuss it at all here today, but there's a lot to look at. And Virta Health is a company trying to really get that out there to everyone via telemedicine.
actually related to that, there is no equivalent for Virta Health for type 1s. There's just the group that, is that correct?
So I don't know the exact answer to that. I know there are people who work at Virta who are endocrinologists who treat patients with type 1 diabetes and are some of the most educated individuals on very low carbohydrate and treating for type 1 diabetes. I don't believe at this present moment that Virta Health has any arm that helps type 1 diabetics. Anything like that that I know of that's currently available, that's correct.
And then down at your university, for example, are the endocrinologists down there who are working with diabetes knowledgeable and willing to use your approach?
So I've spoken to them. They actually invited me to come and speak at their clinic. And I will say that anytime I've ever spoken to anyone about this approach, they're always open-minded once they hear a discussion about the topic. So they actually, they're interested for sure. I will say I can't speak for them, so it's unfair for me to do. I'll just say that anyone I've ever spoke to about this, and I have spoken to them before, they are interested. But I don't know how that translates to real outcomes. We'll see.
And especially for an individual like yourself, I bet you do some exercise. Right?
I do once in a while, yeah.
And it's likely that people with type 1 who are most successful with this are also people who use exercise as a way to manage as well. So where is that coming into what's happening now, both in research and making it helpful for people?
Yeah, so exercise actually, I argue and I believe that exercise is a foundation, something that should be fundamental to most people's daily regimen if you're trying to live an optimal life, a healthy life. Interestingly though, exercise can increase insulin sensitivity, can also cause glucose influx and efflux out of various tissues. So it actually can sometimes make glycemic management a more nuanced conversation. So sometimes people do use it, but that's often in the typical scenario of bringing down blood sugar and using less insulin. But actually in reality, in my situation where I have like flat blood sugars and I go exercise, it's something I have to be more careful about. But it's not something I'm not gonna do. It's something I love. And I think the benefits would outweigh the risk, even if it did cause blood sugars to be maybe not perfect for a short period of time. But for the most part, consistency and learning how to implement it is something that it can be done. And I've seen it done by a number of people, but it takes as a learning process, just like anything. Did I answer your question though? Okay.
I have a question
Yes,
about if you limit yourself to 50 carbs a day, do you spread them evenly over the day, and are they usually limited to fruits and starchy vegetables?
So that's a really important point that I didn't address here. So it doesn't mean you can go get 50 grams of carbohydrates from Skittles, right? It's like, oh, I'm gonna get my 50 carbs in Skittles. Unfortunately, the whole point of those 50 grams of, like less than 50 grams of carbs is actually to get important phytonutrients and fiber from things like spinach and green leafy vegetables. Not just spinach, but there's a number of green leafy vegetables that are available with high fiber content that have very low glycemic impact. So the reason for that is, some of those foods for carbohydrates, if you didn't have type 1 diabetes, aren't like necessarily bad foods, right? See fruits, we've seen a number of evidence out over the years showing health benefits for fruit consumption. But for a type 1 diabetic scenario where that would dramatically influence glucose control in my situation, that's why it's important to have these type of vegetables that have low impact on glycemia. And those are really coming from more of the fibers, high fiber content, green leafy vegetables like fiber and broccoli and whatnot. It was a cool concept while it lasted.
If I'm bolusing for my protein, half of my protein that I'm eating per meal, I count that as carbs also because I'm giving myself insulin for them. Are you saying the 50 carbs a day are in addition to any protein that I'm bolusing for?
So when you say the 50 carbs in addition to any protein, this gets into a unique, so I'll have to say up front, I'm not giving clinical advice when I say this. I'll just say what I do. Protein, when I say match insulin response, the reason people are having, I argue, one of the most important reasons why people are having such success on this low carbohydrate diet is because there's an insulin that currently matches it. I don't know if you're type 1 diabetic or not, but you're mentioning bolusing. If you eat carbohydrates and like you go eat that donut and you inject rapid insulin, I can almost certainly guarantee you it almost never will match the effect because the kinetics, the pharmacokinetics of these, the insulin that you can produce, even though it's rapid, almost never will match the carbohydrate response. This is why it's so difficult to actually manage carbohydrates, is because there isn't a drug that actually does that effectively right now. But regular insulin is what most type 1 diabetics, including myself, bolus with protein because protein has that subtle but prolonged elevation. This is very similar to the pharmacokinetics of how regular insulin, you can buy regular insulin for $30 at Walmart. That's actually what I do. A little side story, I used to use Novo NR on a prescription, and then one day I ran out and I reached out to a group of type 1 diabetics and I said, I don't know what I'm gonna do. And they said, just go to Walmart, it's $30. And I was like, you're kidding me, right? I've been doing this like for 10 years, it's $30? Like, because the other form's over 100. And works the same exact way. So when you're asking a question about bolusing for carbs versus protein, the idea is to have the carbohydrates low enough and fibrous enough to where they're not having really an impact on glycemia, regular for protein, proportional to the amount of protein. Now, if my blood sugar is too high, which of course, as you know with type 1 diabetes, it's not perfect. Even though I feel really good blood sugar control, every day is not perfect. So I need to have something that would bring it down quicker because regular insulin lasts over multiple hours. So I do have rapid insulin specifically for that, or if I have too many of the form of carbohydrates in the form of these green leafy vegetables, because you can overdo those, then I'll use that. Did I answer your question?
Pretty dramatic response to protein. I mean, I can, if it's my first meal of the day and I overdo it in the protein department, it skyrockets me as if I'm eating carbs. So I'm not sure if I'm supposed to be considering that part of my carb count for the day if I'm having to take insulin.
That's so it's a different approach for people doing this regimen, but your glycemia shows you exactly what has been argued by many in the type 1 diabetic community for a long time, that protein matters. The type of protein also does matter. Like things like whey protein quickly elevate blood sugar, much quicker than, let's say, if you were to go eat like a steak. It'd be a big difference, right? And we also know the morning, most type 1 diabetics are more resistant in the morning or have a dawn phenomenon and/or catecholamine response. Something we can talk about afterwards. I can kind of explain what I do in that situation.
So some time ago, I read Dr. Bernstein's book,
Yep.
and 50 years ago, or maybe more even, he was controlling blood glucose in the normal range for type 1 diabetics.
Yep.
So, I'm a scientist, and I don't understand why this didn't take over all the treatment of both type 1 and type 2 diabetes.
So I'm very familiar with Dr. Bernstein. His book, Diabetes Solution, is the most practical how-to guide. I spent 10 years doing this on my own and never knew the book existed, and it literally taught me what 10 years of doing it myself taught me. So that book's incredible. I was one of the things mentioned on the Diabetes Solution slide.
Yeah, that was a great talk. Yeah, I don't know what it is about. It's like every research, RFA now has to be sexier than diet for type 1. It's got to be islets, it's got to be immunotherapies, it's got to be extending that new onset phase. What I've always thought was funny is any of these studies that employ brand new onset patients with type 1 to try a course of immunotherapy will never change the diet at the same time. I've always thought that sort of blown my mind, when it's been shown in lots of studies that the beta cells under stress are different than the beta cells not under stress. You can exogenously give NOD mice insulin, right, and it retards the whole autoimmune process. But people, new onset patients where they've still got some remaining beta cell function and they'd like to hold on to it,
right,
they don't put them on anything but I think an AHA recommended diet.
So there, specifically to your question, there's actually been work out of a group in Hungary, like almost 10 years ago, showing that they were able to, it's limited studies, limited population, these are case report like studies, but, and there's a recent report that confirmed these findings that individuals doing a low carbohydrate approach as a mitigative strategy, once they realize they're on the downturn of their beta cells starting to be destroyed. Because it's not an overnight thing. It's not like you walk in the clinic and you're like, okay, my beta cells are all destroyed. As you know, it takes time, right? But there's been some case reports recently, and this is limited data, but there's been like 3 studies out of Hungary already indicating that this may help mitigate the destruction of beta cells. That's super preliminary though, because it's super limited data and it's case report-like findings. When you talk about combining diet with immunotherapy, at least from my mind thinking about it from like the scientists and our research, when you do an approach and you see it works, you're hesitant to do another approach that may change your whole physiology, which we know a diet like this can do, simultaneously with this other therapy. So it's understandable that people will be very resistant to try 3 things at once instead of just 1, because there's many scenarios where stacking things can actually counteract the beneficial effect of one thing. So there's reasons to be cautious about that. And when you mention diet's not as sexy as things like these other things, well, there's a practicality to this too. If you have a drug that you can consume, this is much easier. I mean, there's no one who would argue that it's easier to just take a drug than to change your diet. We know that. I mean, this is also part of the other previous question, kind of the off-hand comment, but in reality, it's much more difficult to implement a diet. It takes real lifestyle change, and we know people have had a difficult time with that, with diabetes management, being overweight. So over 70% of the population in America now is overweight. But we know that diet and exercise can mitigate that quite well. There's obviously nuance to that, but it's not easy for everyone, and because of that, people are looking for quick, easy solutions, but oftentimes they'll never be as good as the hard work.
A sports camp, sports, low carb, endurance, combine the
There's
two.
people who are trying to do low carb camps, by the way, so.
Yes, have you found any correlation between the low carbohydrate diet and diabetic neuropathy?
So, well, we know that glycemic mismanagement and elevated blood sugars can lead to diabetic neuropathy. Actually, retinopathy is, in type 1 diabetics, it's believed that something like retinopathy, these microvascular-based diseases, can actually, over 80% and up to 100% of type 1 diabetics within 2 decades, 20 years post-diagnosis, and over 85% of patients with type 1 diabetes are diagnosed before 20 years of age. They're expected to basically have impaired vision and or have maybe no vision within 2 decades. Things like retinopathy are amongst that category of very prone to be damaged by elevated blood sugar. Is there evidence that it can be reversed? To my knowledge, currently, I don't know anything that's in the literature right now besides anecdotal reports of individuals describing their improvements, but to my knowledge, there might be, I don't know of it. So that's just a fair answer, because I don't know if there's any evidence right now. Yeah, I don't know. I'll be honest, I don't know.
Okay, everybody, thank you. Let's show Andrew some appreciation.